Today's talk is going to be about biocompatibility testing. Specifically, what types of biocompatibility tests do you need to prepare and submit reports for if you're doing a 510K submission? Um, and I'm just going to double check the quality of the picture here because last week I was sitting too far away from the camera. Quality was horrible. Now, one of the tools that everybody tries to use is a matrix like this one. So this one's provided by Nelson Labs. It's free from their website. You can also get a very similar table that this is based on from the FDA guidance document, and you can also get one from the ISO 10993-1 standard. So that's 10993-1. So if you're familiar with biocompatibility testing, you already know that standard. That's the high-level top testing requirements document. And then down below that, you have other specific standards for the individual tests. For example, there's a -5 standard that's for cytotoxicity. There's a -10 standard for irritation and sensitization. There's a separate standard for how to do the extractions. So every single one of these standards has a different purpose. There's a -7 one for EO residuals for ethylene oxide sterilization. You have to figure out which of these standards apply to you by reading the ISO 10993-1 standard. And I believe the most current version is the 2018 version. I don't think there's any amendments. There's, of course, an EN version, but if there's an amendment and I'm wrong, my apologies. But in general, that's the standard that everybody's following. Now, for a little bit of history, when the standard changed in 2018, the history behind that, and I know this directly from the source of the person that was in charge of the committee that rewrote this standard, they came up and introduced with the concept of a biological evaluation plan. And that person was from this company. So they said, the way we're going to do this is we're going to have a plan, then you're going to do the tests according to the plan, and then you're going to have a report, a biological evaluation report. And the intent of this approach was, if you have a material that you don't know whether it's biocompatible or not, you might do certain tests, and based on those results, you might do more tests or you might do less testing. And it's only for products where you don't already know whether it's biocompatible. Most of the medical device industry picks materials that they know are biocompatible, and they're just looking for proof, a report showing that there's no residuals or contaminants from the packaging or sterilization or cleaning or manufacturing process. They're going to cause biocompatibility issues. For example, if you're making a titanium implant, there is no regulator on the planet that is concerned about whether titanium is biocompatible or not. That's not what they're asking you. They're asking you, is your titanium implant biocompatible after you have cleaned it to remove all the metalworking fluids that you use to machine that titanium implant? So all those metalworking fluids are not good for you. And there's all kinds of oils and detergents and solvents. Those need to be removed from your titanium implant. So that if they're not completely removed, you could have a problem. So that's what they're asking. So just because you used a medical grade implant material, that's not enough. You need to use the same manufacturing process, the same downstream processes for cleaning and removing any debris and metalworking fluids, and you have to use the same sterilization process. So if you change any one of those, you change the raw material you're using, you change your manufacturing process, you change your cleaning process, or you change your sterilization process, any one of those will trigger you need to repeat your testing. If you'd use the exact same thing across the board, you do not need to redo your testing. If you've submitted a 510K before, you can use what they call a biocompatibility certification statement that says we're using the exact same materials, the exact same process, the exact same downstream cleaning process, exact same sterilization method, and this is the exact same geometry or similar enough geometry that it doesn't pose new risks. The geometry issue is sometimes important. I'll give you an example. Metal on metal hip implants that you may have heard of back in the day, 2007, 2010 timeframe. We were seeing metal on metal implants showing a lot of cytotoxicity to the body because these were implanted and they would wear on each other, and there would be little itty bitty debris that would be left in the joint, and that would kill the cells around it, and you'd have aseptic loosening and cell death, and in the skin or the tissues around the implant would actually turn black. At the beginning, it wasn't like that because it's a nice, pristine, pure, clean, polished implant that isn't going to go inside the cells. But as you have wear particles, these wear particles can be so small that they can get inside a cell and cause the cell to die. The body reacts to these either by encapsulating or digesting it, not like we digest, but like a cell digests. It sucks it into the cell wall. It tries to use it as a material. And titanium, little particles that can be absorbed by a cell, are going to kill the cell. Whereas a large piece of titanium is going to be completely inert to the cells, and they're just going to encapsulate, work around it. So that's what we want. And unfortunately, with metal on metal implants, that didn't happen. The more common approach for knee implants, hip implants, shoulder implants is to use a poly material. So it's ultra high molecular weight polyethylene. It's a very long molecular weight polyethylene chain. It's very similar to the same stuff we use as a negative control in the testing labs. And it's a soft material that's the sacrificial wear material. So the wear particles you get in the joints are polyethylene materials that are much safer for the body than titanium wear particles. So it doesn't mean you're not going to have any issue with these wear particles. It just means you're going to have less than you would with metal wear particles. So these are the kinds of things that we're looking for and why we do these tests. Now, which test do you need to do? And everybody wants to say it depends, but it really doesn't depend all that much. There are some very basic rules that you need to understand. And before you even have designed your product, you can nail down these are the tests that I'm going to have to do for this kind of device. So the first question you need to ask yourself, regardless of what country you're going after, is what is the type of body contact that you're going to have? Is it a surface contacting device? So this means my skin, whether I have a cut on my skin or I don't have a cut on my skin, it's still skin. So this is surface contacting. We include mucosal membrane in there. So eyelids, mouth, vagina, these are mucosal tissues. So they're going to be a little more sensitive, a little more testing required potentially for those particular tissues. But the surface contacting devices, if you have intact skin, it's a very short list. If you have mucosal, it's probably going to be a longer list. And then if you have breached or compromised skin, it's going to be even longer list. And you have the duration of contact. They have a category A, category B, and category C. Category A means this is a transient or short-term duration of contact, less than 24 hours. Short-term means it's going to be more than 24 hours, but less than 30 days. And then implant is a long-term duration. It's anything over 30 days. So like a hemodialysis catheter, it'd be more than 30 days. They also, now this is where the FDA might be different from your notified body. They look at how many times is the contact potentially if you have subsequent contact. So you're going to use this device more than once. With a hemodialysis catheter, even if you said this is for less than 30 days, it's going to be used multiple times because you're not going to just be on hemodialysis for 30 days and then never have it again. You're going to be on there until you have a transplant probably, or you die. So in these cases, when you have a device that's used many, many times, it's not just the short-term exposure with this device, it's the cumulative contact from multiple devices over time of the same materials. So you have to consider that into the duration. But the first question is the surface contacting, is it intact skin, mucosal tissue, or breached or compromised skin? Something like a burn or a cut, a laceration, those would all be breached or compromised. The second category is externally communicating. This means you have a device that's both inside the body and outside the body at the same time. Needles, catheters, those are examples of externally communicating devices. You could also have, like if you had a dental implant and it's a unipost, so it's all one piece, you don't have a post and abutment, that could be externally communicating as well, because the top part is outside the body and the bottom part is inside the body. But they're probably going to take the worst case part, the part that's inside the body, because it's there long term, and you're going to have the same kind of tests. Normally, when we're talking externally communicating, it's the kind of device like a needle or a syringe or a catheter where you're able to transfer material like a drug or fluids from one part of the body or one part of the body to outside the body, or outside the body into the body. And that's what they mean by externally communicating. And we have three different categories again, just like we had for skin. But for externally communicating, we have blood path indirect. So this would be the syringe. It's not inside the body, but it's communicating with the inside the body indirectly, because whatever was in that syringe goes into the body. Then we have tissue, bone, dentin communication. So that would be the example I gave of something that you're going to have in touch with your teeth or your gum. It could also be something that, let's say it's a catheter that's going to be in touch with these tissues, but it's not one that goes into not going to go directly into a vein or artery. It's going to be used for, let's say, drainage. And then another type would be circulating blood. So if this is actually used for a shunt or something for diabetics or somebody that's being on dialysis, you have these shunts to help assist in the flow of the blood in these, and as well as connecting to a hemodialysis machine. These particular devices are going to be in direct contact with circulating blood. Another example, the third category that we were talking about is implant devices. So this would be like an orthopedic implant or a heart valve or like an IVC filter. These would be devices that are either in direct contact with tissue or bone. That's one subcategory. And then they have another subcategory that's blood. Both for the externally communicating and the implant devices, we still have ABC for short-term, less than 24-hour transient, short-term 24 to 30 days, and then the long-term implants that are more than 30 days. So those are the categories. And I'm sorry that was so long. Sorry for the people that already knew it. I'll try to put some timestamps so you can skip through that part. But hopefully this is helpful to you people out there that have never done this before. And if you have somebody in your company that's new to medical devices, share this link with them. This will really help them understand. And you can even select, when you share links, you can share specific timestamps. So I'll give this section, this will be about categorization of biocompatibility contact. And you can skip over that section, or you can just watch that section, because it'll really help people. Now, once you've determined the categories, you not only have to think about the categories for your device, but you might have to think about it for different components of your device. For example, you could have one component of a system is only touching the skin, and another component of your system is going to be invasive, and it might be externally communicating. So you could have sensors of two different types. In those cases, or different parts of the device, you might want to say, this part of the device has this type of category of exposure and body contact, and therefore we're going to test it according to these criteria. And this other part of the device, we're going to expose a different way. And I'll give an example. If you had a CGM sensor, a continuous glucose monitoring sensor, the housing of the device is going to touch your skin whenever you press it onto your skin. The adhesive is going to touch your skin. But the needles, that are going into your skin, those are externally communicating. So the needles, you want to do the externally communicating tests. In the housing and the adhesive, you're going to do the surface contacting only. And they might have different durations. The housing, you're only going to touch transiently because you're only holding it for a few seconds. You might not need to do that testing at all. You might be able to provide a rationale. Might. The adhesive is going to stay on your skin for a long period of time. And so you may want to be testing that for a long-term exposure. And a lot of people get allergic reactions to adhesives. So that would be an important one to look at. But the needles, those are going to be poking through the skin, and those are going to be externally communicating devices. And each one of these you want to test differently to different test standards. So unfortunately, you could conceivably be testing the whole thing once, or you could test each three of the components in 3 different sets of tests, and now you're paying for 9 different tests instead of 3 different tests. The problem is all the electronic circuitry that's inside that sensor, you don't want to test because those are not biocompatible, but they don't have to be. They're not going to actually communicate with the body in any way. There's no indirect contact, there's no direct contact. In there, they have silver in there, they have gold in there, they have copper in there, they have potentially lead in there if you have leaded chemistry. So you have all kinds of potential heavy metals and toxic chemicals that should not be in contact with the body. So you need to remove those. But because the way they do the biocompatibility tests, they actually do an extraction of the sample device that you provided. If you extract the whole sensor and it's not 100% sealed, then you could have some of those toxic chemicals extracted out and cause you to fail a test. So if your company is thinking about, we want to just test the whole thing to the worst, most difficult tests there are, we're going to test the whole system, the finished device, to all 3 tests, and we're not going to have to do any further tests. Or actually, it'd be more like 5 tests. If you were going to do that, you might want to start with a cytotoxicity test. And the reason why, that's a very sensitive test, and it could be done very cheaply and inexpensively and quickly to see if you're having any problems when you extract the entire device. If it extracts some of the material from inside the housing, you're going to fail. If it doesn't extract some of the materials from the inside because it's completely sealed, you're going to pass. So this is your way of testing. Can I test the whole unit as is, fully assembled? If I can't, because it fails, then I use that as a rationale for why I have to create a special sample just for this, where I take all those components out. And you also have to think about, what is the surface area that I'm contacting? It's going to be very different if I can touch the inside of the housing and the outside of the housing than if I can only touch the outside. The relative surface area that's exposed to the extrat is totally different then, and it changes the results. So these are some of the considerations that you have to come up with in your testing plan when you're going to do biocompatibility testing. But if you have something where you don't have to worry about electronic components, and you don't have to worry about 3 different types of contact, you just have 1 type of contact, 1 duration to worry about, that makes it really simple. In these cases, and that's a lot of devices out there, you can just look on this chart and it says, do this, this, and this test. So let's say I'm going to do a bandage test. So I'm going to test the whole entire bandage. Well, this is going to come in contact with breached and compromised skin because it's a bandage. And so I look at these columns. If it's short term, the A, I have to do what we call the big 3 tests: cytotoxicity, sensitization, and irritation. And then there are 2 more tests that I have to do: acute systemic toxicity and material-mediated pyrogenicity. So I have to do 5 tests. The chart says E next to each of those. That means evaluate. What the chart used to say is X, which means you have to do it, and O for it's optional. Some things were optional, some things were not so optional. The only thing they have access to now are physical/chemical information. That does not mean that the FDA wants you to do chemical characterization when you have that column checked. What they want you to do is provide the information about what your device is made of at the chemical level. So if I have a polycarbonate housing and it's 100% polycarbonate, I can provide a cast number, I can provide a grade and brand of that particular resin, I can say it's molded, I can say it's 100% polycarbonate. If it has an additive like a colorant, I have to say what percent colorant. So I made it blue, it's a 2% colorant. This particular cast number for the colorant, this particular resin model. That's the kind of information the FDA wants when they say physical and chemical information. But if you don't know what your material is made out of, then you're going to have to do extractables and leachables testing, or E&L testing, which costs a lot of money. You're going to have to see what is extracted out of there using the extraction process, and then determine whether each of those things that gets extracted is toxic to the body or not. That's going to be a much more extensive process, and they have a brand new standard that's come out, a new version of the extractable leachables for chemical characterization. So if you don't know, you got a lot of work and a lot of cost ahead of you. If you know exactly what it's made out of, exactly how it's made, you can provide that information directly to the FDA in the form of MSDS sheets, cast numbers, and technical spec sheets or data sheets for each chemical that's in there. And if there were any questions, you say, well, this is already used on this other product. Why do you know that? Because most contract manufacturers make products for more than one company, and you know who else is using those kind of products. Or maybe you have a previous version of your own product that uses that same chemical. So you could answer some questions. But if you provide the cast numbers, the MSDS sheets, the technical data sheet for that resin, plastic that you're using, or metal, whatever it is, and you do each of the tests that are marked E, you should have no problems getting through the FDA. But if you choose not to do certain tests and provide a rationale, that's where you need a biological evaluation plan, or BEP, and a biological evaluation report, BER, both of which are written by a toxicologist that knows what they're doing, has the ability to look up what each of those chemicals are, determine their toxicity, and determine whether people are going to be exposed to something that is potentially at a toxic level. And you're going to have to get that reviewed and approved by the FDA as a plan in your pre-sub, and then you're going to have to follow it. So if you want to skip all that part, just do the tests that say E next to them, and you don't have to do that BEP and that BER for your 510K. If you're doing CE marking, that's different. Now they're going to say, well, you have to follow this 10993-1 standard. It says you have to do a BEP. It says you have to do a BER. It doesn't provide an option for not doing those. So they've actually created more work for you, force you to use a toxicologist, and require you to spend more money. I wonder who might have written that standard and required that BEP and a BER. Maybe a toxicologist that is going to be the person doing that work. So if you're wondering why it's different for Europe and in the US, the FDA said, we want it done the way it's always been done. We have a guidance document, and they've updated it since the 10993 standard was updated. But at the same time, it's a lot of, this is the way we've always done it. Do these tests and tell us what your device is made out of, and you're done. If you're doing CE marking, they're going to want you to follow that standard to the letter, do your BEP, do your BER, evaluate which ones you can do, which ones you don't have to do, and you might be able to justify out of some tests, but you've increased the amount of work you have to do with the BEP and the BER. Now, how do I know what tests to do? Have you ever heard a story about, like, well, we did exactly what tests we were supposed to do, but then the FDA said the lab did the wrong version of the test? That happens all the time. There is a secret way to avoid that. And we've discovered this recently through the E-Star submission. The E-Star submission, next to every single question that they ask, they usually have these little help buttons. So you click on the help buttons and it will help you understand what the FDA wants. But when you come to the biocompatibility section, and you answer the questions, it gives you little blue squares or rectangles saying, here's each of the tests you need to perform. And when you click on them, so let's say we click on the cytotoxicity one, it will say, here's all the questions we have about your cytotoxicity test report. And they will ask you questions, and you select from a drop-down menu as to which version you did. All this options in the drop-down menu that have asterisks next to them will have extra questions. You want to probably avoid those at all costs. It doesn't mean you can't do them, but it means you have to provide more data, more explanation, and that's going to slow your review down unless you provide all those answers adequately right from the start. You're much better off picking the ones that don't have the asterisk next to them, because that's the one the FDA expects, because that's what they always see. That's the way we've always done it. Do it that way. So when you ask for quotes from the lab, it should be based on those blue boxes that you see showing up in the eStar before you've even done the tests. So answer the questions. It'll tell you which tests you need to do, and then ask for quotes from those. When you review the quotes, ask them, what solvent are you using? What conditions are you doing it for? How long are you extracting it for? They may not want to give you the full protocol until you've paid a deposit, but they should be able to tell you what extraction method they're using, what temperature, how long, because you need that information to determine whether it's the right method or not. It's the method the FDA wants. So I did that with several clients recently, and we got 0 questions about biocompatibility because before we even did the testing, we made sure they were doing the test the way the FDA wanted it done. And so that way, when we attached the report, all the questions were already correct, and we didn't have any problems with the FDA review. So use the eStar proactively in your planning process when you're getting quotes for biocompatibility. Make sure you do all the tests that they have the blue boxes for, and make sure you look at all the versions and questions they're asking to make sure you select the right test method and the right extraction conditions, and you have the right information in your reports. So when those reports come back from the lab, they're all done. Make sure that information you're looking for is in the report. That's how you can say, yep, this is good, I accept this report, or no, this information is not in here. It doesn't say whether the guinea pigs were pregnant or not. Well, or where they were separated male, female from birth. So if you don't get that information right away in your report, kick it back to the lab and say, I need this information because the FDA is asking what page can it be found on. So that's how you do your biocompatibility testing, and make sure that it gets through the FDA. It's a very different method than what we do for Europe. What we do for Europe is we just follow 10993-1 and do exactly what it says. For the FDA, you read their guidance. You use the eStar. You only do the tests that say E next to them. And if you're going to try to justify out of anything, you either have a biocompatibility certification statement, or you have a BEP and a BER that the FDA agrees with in advance during the pre-sub. I hope that helps everybody out there that's struggling with trying to get their biocompatibility testing done. If you follow this method, you shouldn't have any problems. But if you have questions and you haven't spent the money yet, come to us and we'll be happy to help you through it. Have a nice day. Bye-bye.